Welcome to the session where the focus is mapping and targeting AF drivers, from de novo to redo ablation. I'm joined by our case presenters, Saumil from Jacksonville and Anish Amin from Columbus. We're also joined by our panelists, Gery Tomassoni from Lexington. Welcome to you all. Now I'll hand it over to Saumil and Anish to take us through the case.
So thank you for having me, first of all. I'm going to be talking about mapping and targeting AFib drivers outside of the PVI, particularly in redo ablations. I'll be giving a case of a redo ablation. But first, here's my disclosures, and I'll be talking a little bit about the technology. So the VMAP takes a 12-lead EKG, and it analyzes cardiac arrhythmias and provides a probabilistic location of sources to guide ablation therapy. So in this example of atrial fibrillation, if you look at the blue columns, it actually looks at the EKG between the T wave and the next QRS and analyzes that area through an AI-based algorithm and gives you the most likely area that is causing the atrial fibrillation or that is driving the atrial fibrillation. It essentially simulates atrial activity, or the way electricity activates through the atrium to reveal areas where conduction breaks down. And it identifies patient-specific hotspots and evaluates AF sources across both atria. And it compares this electrical activation against about 400,000 simulations it's run in various anatomies and various ablation states with varying degrees of scar. And it locates and highlights areas of conduction slowing or scar, looking for wavefront slowing, curvature, and reentry. So it shows both rotational and focal atrial fibrillation sources. So if you look at this early study that was presented at the AFib Symposium last year, it's a pilot study of about 80 patients randomized 2-to-1 with two-thirds in AFib PVI alone versus PVI plus VMAP guided ablation. It showed a significant improvement in freedom from atrial fibrillation of 48% versus 86.5%. And when you look at all the location of the drivers, the anterior LA was by far the most common, but you also saw unusual locations such as the right atrium in almost half the patients. So that leads up to the Improved AF study, which is a multi-site randomized clinical trial with 27 sites across the US and Europe, analyzing about 423 patients of both de novo persistent and redo AF ablation patients, looking at, like I said, 423 patients enrolled to obtain a sample of about 167 patients per arm. The primary endpoint is going to be freedom from atrial fibrillation at 12 months, with secondary endpoints looking at freedom from both AFib and ATAC at 12 months, total VMAP mapping time, AF burden, percent of subjects with spontaneous AF termination, and total fluoroscopy dose, with the thought that this technology may actually make the procedure more efficient in these redo and more advanced AFib patients. We're also finishing up the VITAL EP study, where we're looking at pretty much any arrhythmia and looking at efficiency and real-world clinical utility and safety of this technology. So now I'll go over a case study of a case that we did recently. The patient was a 70-year-old lady with a history of atrial fibrillation and ATAC with a prior PVI and posterior wall isolation using PFA. She presented for a redo ablation with more of an irregular atrial tachycardia. She had incessant rapid atrial tachycardia that was very irregular. We started the case, and all we saw initially was PACs. We had the 12-lead analyzed on VMAP before we even put the catheters into the body. 3 PAC morphologies were seen, and we used the VMAP findings to guide the initial ablation mapping strategy. And the goal was to identify and ablate recurrent AF and ATAC drivers using this VMAP-guided approach. So if you look at the first map, the initial PACs localized to the septal RA-SVC junction with some blanching to the left atrium, and all 3 morphologies kind of map to the same location. And this is a corresponding electrogram in the area. This is in the right atrial septum. So you can see there's some fractionation and some early activation in that area. So we went across the left side just to see, make sure our PVI was intact, and everything looked fine from the previous PVI. We ablated on the left atrial septum, kind of where the blanching was, because we saw some fractionation there in the periscar area. And as we were doing this, we found an atrial tachycardia that began occurring. And first it was infrequent, then became more frequent. And it was a specific atac that localized to the superior crista terminalis, kind of on the opposite side, on the lateral side of the SVC. And this is the electrogram we saw in that location. However, there are several different atrial tachycardias, and a lot of these were an irregular atrial tachycardia, and we actually looked at each different beat of that irregular tachycardia, and it localized to different areas. This is in the mid inferior crista. And then this is the electrogram. We see a good mid diastolic potential. But as you can see, it was basically every other beat was a different tachycardia, and we had to map each of those, and we found a third atrial tachycardia that localized to the inferior crista. And these were all kind of occurring simultaneously, and it was very difficult. We really wouldn't have been able to map this. We were trying to map it, but because there's so many different tachycardias and they're coming on and off, we couldn't really make a great activation map. So initially, we isolated the SVC and got rid of the blanching, got rid of the initial focus of PACs on the septum, on the right atrial septum. And then when we did more substantial mapping in the crista area, which initially we hadn't done, we did see some low voltage in that area along the crista terminalis area. And the green dots show the fractionated electrograms we saw, and this very well correlates with the VMAP electrograms. We made a cavo line kind of incorporating all those fractionated electrograms. And by the end of the case, there's really no inducible tachycardia. The incessant atrial tachycardia, as well as the PACs, all terminated, and we just had sinus rhythm at that point, despite isopril. So the takeaways from the case is that a VMAP really localized this multifocal atrial tachycardia across the RA, mainly, and a little bit on the LA side. It correlated with low voltage substrate on cardo. We're able to guide using this VMAP to targeted efficient ablation and procedural success. I think this would have been a fairly difficult case without VMAP. I think we would have maybe eventually found some of those fractionations, but it certainly made the case much more efficient. Any questions?
Saumil, I think we're going to let Anish kind of do his presentation, and then maybe we can do questions together. I don't want to take the thunder away from him.
All right. Thank you. Okay. Well, that was a great introduction by Saumil around the technology and how he's utilized it in the redo setting. I wanted to maybe describe how we utilize it in our de novo ablation patients, and then reinforce a little bit of what Saumil talked about as far as workflows. So a couple of disclosures here. I wanted to present this case of a similarly aged patient. He's actually 74 years old. He's got a history of a gastric bypass surgery, and he came in with persistent atrial fibrillation. Now, Devi, you know that from our days working with Farapulse, which has been our workhorse in our lab over the last 18 months or so, and particularly with the Advantage data set, in many of our persistent patients, our anatomic strategy has been fairly straightforward. We do a PVI and a posterior wall, but many of these patients return, and we're often left with questions around, should we have done something a little bit different? And in this particular case, while mapping in atrial fibrillation, we identified both in anteroseptal, particularly just anterior to the right superior pulmonary veins, and then a true anterior hotspot with no posterior wall activity or RA activity identified. So this is a FARA-VIEW map, and so you can see it's a relatively low density map, but nonetheless gives us the lay of the land, which generically kind of shows what we'd expect in a patient with persistent atrial fibrillation with heterogeneous voltage across the posterior wall. And if you look at the right lateral view, what we see is that low voltage anterior to the right veins. And this is, I'll get back to this here in a second, but of particular importance, I think, as you've shown through the day to day, the different strategies that we use with single shot PF and how we need to potentially change our ablation strategies to make sure that we're including more than just the osteal ablation and encompassing the an antral footprint for ablation, and this is one way to help us clearly identify that. So again, this is the uh, uh, PA view that we're looking at along with the left lateral view, and you can see that there's really not much to speak of on the left lateral side. So we're our voltage map is relatively consistent with the vector analysis. This is the analysis as Saumil described to us. So we see that in between the T wave and the QRS, we're taking multiple segments of the ECG and analyzing it in reference to the nearly 400,000 simulated models, and then demarcating the hotspots again in our particular patient, just anterior to the right veins and on the anterior wall. So just an animation of that, and where we located that. So what does our ablation look like? Well, it looks like a fairly typical Farapulse ablation. We've kind of toasted the PVIs and the posterior wall, and then as we're ablating at the anterior edge of the RSPV, the AF organizes an atrial flutter. We again look at VMAP to help us identify what exactly this atrial flutter is. Not that we necessarily need VMAP to highlight an organized arrhythmia like atrial flutter when we can map with an intracardiac therapy catheter or diagnostic catheter. But it's certainly nice to showcase that in this particular case, what we saw was that a perimitral flutter is what was present, and we ultimately did a lateral isthmus line, and the patient went into sinus rhythm. We pushed a little bit further and asked in this particular case that we like we do in most of our persistent patients, to pace to atrial refractoriness and also test with isoprel. And what we induced was a typical flutter, which I'll show you, but this is just a map of the Fairview map of the atypical flutter and then our subsequent ablation map. After the induction of typical flutter, we see that we have a hotspot that coincides with the CTI line. We ablate here, and the patient returns to sinus rhythm and is no longer inducible. So for me, the key takeaways are that when we use VMAP, we're going to be able to extend our lesion set, not in an indiscriminate way. And I recognize that, like, the map I show, and Dr. Tomassoni will comment on this, I'm sure, is one that's relatively anatomic ablation out of the box, PVI posterior wall, but certainly one that pushes us to take a care of how extensive or how reduced our lesion set should be when we have the additional information through the vector analysis. In addition to that, I think that as Saumil mentioned, the improved AF trial, this will lend even more data around what I think is a relatively fair critique, which is to say, can the complexity of atrial fibrillation be summarized and evaluated through something as simple as an ECG? And I think many of us, recognizing that our ablative strategies have become so efficient and in some ways very elegant, we need diagnostic solutions that fit that as well. And Saumil described how in his patient, the VMAP was being done during the case. And I think that's a point that should be emphasized, that multiple ECGs can be analyzed throughout the case in rapid succession. But we can also look at these ECGs in the clinic setting, so we can predict what our um, lesion set, what our workflow, what therapy catheter or therapy solution we want to use, even before we get into the lab. And that's a very potent way for us to maximize efficiency and have a true conversation with our patients around what it is that we're going to be doing when we ask them to undergo an AF ablation. Take it back to you, David.
Well, Anish, that's a great segue. Gery, I'm going to start with you because I called you for this session. So I wanted to hear from you. Where do you see the value of such a system the most? Is it pre-procedural, like Saumil said? I mean, he knew what he was getting himself into, or is it more intra-procedural, which looked like Saumil used it in both places, or is it? Do you use it throughout the I guess the life history of the patient in the lab?
Yes, I mean, thanks, Devi. I think that those two cases are just wonderful cases showing the utility of the system. To answer your question, I use it across the entire pre, post, and then intraoperative situation, especially in a situation where you're going from what Dr. Ozo showed, these rapid atrial tachycardias, PACs, basically occurring simultaneously, in addition to trying to localize atrial fib sources. It's great. And I think the two cases that both these guys showed are really does show the ultimate utility of this system, all based on a 12 lead EKG and a map that takes less than 3 minutes to do.
Yeah, I have to say that I was very pleasantly surprised at how short a time it takes for you to get something like this, and especially in the clinic setting. I think one of the things it's I think important for our audience to know is that because especially if you do it in the clinic setting, it is considered a pre-procedural kind of imaging mapping strategy, and it has coding as well, so it is a billable procedures, if for that matter, for the time that you actually take and look. And to me, what I felt when I started using this, at least I've only used it in the clinical trial for improved AF, is I get to kind of give the patient an idea of what they're getting themselves into, not the fact that let me do what I can and then let me come and tell you what I'm going to do. It's more a more prescriptive kind of methodology. Uh, Salma, let me ask you a question about um, you've had some more experience with this system. What's your success rate been? Like, how often are you seeing the correlation? Like, are you targeting termination? What does that termination even mean to you in this world of PFA? Uh,
Yeah.
or are you looking at, do you have data on chronic outcomes?
So, we haven't used it long enough to really have chronic outcomes. Some of the things that we look for, we do look for termination sometimes. We don't see it super frequently in atrial fibrillation, but I think just to get the concept of the technology down, we use it a lot in PVCs. We use it in atrial tachycardias, things like that, and it's usually spot on. I mean, we haven't seen too many that are too far off from the actual termination site. So I think from a concept and just a usefulness of the technology, that definitely is there. For AFib, we generally we'll give it a few rounds maybe and try to find a few different drivers of atrial fibrillation, but we don't always go to termination with it. So I think with the improved AF protocol, we're just going to be starting that, I think, in the next few weeks. We'll kind of see where that goes. I think that's going to really answer that question, and that's what's needed in this space. We need these randomized trials that really show the utility in atrial fibrillation.
Yeah, I think that's important.
Yes, I mean,
Oh, sorry. I was going to say, I think from a focal tachycardia perspective, PVC AT, the VMAP study did demonstrate high reliability to um, understand the location of the tachycardia or ectopy within one myocardial region, and it's really in those fibrillatory tachycardias that Saumil described that we need this data set from improved.
So, Anish, while I have you, you are a proponent of efficiency and throughput, and as we start evolving and taking these ablations into ASCs, do you see a value of systems like this in improving efficiency, throughput, um, risk stratifying or categorizing patients that could or that need to go to certain specific locations for their ablation?
I do. I think that, obviously the ASC conversation is hot on everybody's mind with yesterday's formalization for codes in the US. And we're going to have to, as a community, understand which patients are best suited for the ASC environment and which patients are better suited for the hospital environment. Utilizing a solution like this gives us the opportunity to understand what the depth of the lesion set may look like, and how challenging or complex that may be, and will give us some idea of where these patients should be cared for. To that point, I kind of briefly mentioned this. I- in many situations, in the abstract that Samo presented, the sort of that just in front of the anterior right veins was introduced as a common site. And I think we know when we're using these single shot technologies that, and was described earlier today through the sessions, that the catheters seem to fall, they seem to not provide us as much of an antral lesion. And I know that you have described your workflow with single shot technologies for PFA. And this does give us an idea of if we need to extend this out a little bit further, help us plan like how much ablation we need to do, even if we're just going to do a PVI only, if we're just going to tweak it a little bit. um, so in that regard, as we think about site of service changing, we want to be really careful to understand, what type of time commitment we're going to be taking. Is it going to be a PVI modified, or is it going to really be a PVI plus?
Yeah, it's a great point. I guess as we move on to using PFA and having all these tool sets, right? We have these large footprint, medium footprint, focal catheters. I think it is important. You get asked the question every time: how do you pick what catheter to use? How do you pick which energy source? I think understanding what we're getting ourselves into is going to be very important. Gery, let me ask you a question that has bothered me about technologies like this. So, and I don't have enough data, so I'm going to ask you to give me the answer. Uh,
Mm.
do you feel like you have seen correlation with substrate? Because we've, historically gone after substrate, and we had erase AF and all kinds of trials that kind of targeted substrate, and then we have substrate data from MRI that didn't pan out. But triggers like this, this is electrical substrate, right? Electrical substrate, does that correlate with myopathic substrate? Have you seen that?
Yeah, I mean, from a standpoint of using the combination of vector with ventricular arrhythmias, ischemic, non-ischemic PVCs, we definitely see a high correlation between the identification of the arrhythmic source with vector and substrate abnormalities in the ventricle. I think in the atrium, we're still working through that. And I agree, initially we were very aggressive with all sort of electrical slowing and high frequency signals in the atrium, and data really didn't pan out that you should be taking down these sites. But what we're seeing with vector in the atrium right now is that it doesn't correlate all the times with some severe slowing or electrical abnormality that's located. And so I do think an important part of the vector localization is identifying functional areas, not structurally abnormal areas. And hopefully that will bear out on the improved AF trial that we'll be looking at.
I have to say that one of the things that noticed, and it's a habit changing thing, is I routinely do if I'm doing mitralismus, it's usually a posterolateral mitralismus. And we recently had a patient that randomized to the vector arm of the improved AF, and it highlighted the anterior wall, and I, it changes what catheter I pick for the AF ablation, and because there's so many tools that's available. If only you have only one tool, that doesn't matter. But like, I have access to a lot of tools, and so it really kind of, I've started to get the feeling of what am I going to use this technology for. Now, Saumil, let me ask you a question about, I know we talked a lot about atrial stuff. Do you see that, I almost feel like this is one of those that really is going to help in the ventricular space as well, quite a bit. Because it's not, everybody, I mean, AFib ablation has become something that happens in every lab now, whereas ventricular ablation still hasn't gained that momentum, right? So there are centers that are, of course, high excellence centers, and then, there are people that kind of dilly-dally in the ventricular space, and then there are people that just don't do it. But I feel like if you could risk stratify which are the patients or areas in the heart where, you're not going to be able to reach in your center, and maybe they should go to areas, or centers where they have tool sets for that. And so, is that something that that has been a thought process within the company, within the technology development stream, to take?
I think that's. Yeah, I mean, I think that's what in the ventricular space, that's going to be one of the most useful aspects of this, because it tells you if it's epicardial versus even versus endocardial, and very very discrete kind of findings in this with this technology. It has a lot of almost to the several millimeter accuracy, whether it's epicardial or endocardial. So if you're getting into something that you're going to need to do alcohol ablations within the septum, or epicardial ablation, and you're not real comfortable doing that, if the technology, if we get more and more data showing that this is truly as accurate as it seems to be, I think a lot of places would just refer right off the bat, rather than go after these difficult tachycardias and PVCs. So I do think that's going to be important. And I had a quick comment on your anterior ablation. We've used a lot of different technologies and in this AI space, and different things to actually map atrial fibrillation. And one of the common themes of that is most of these technologies do identify sources in the anterior wall. Because of that, I've really slowed down on making my lateral lines, because I'm worried about isolating a big chunk of the heart when I do have to go after those sources in the future. So I think the anterior wall is pretty important in atrial fibrillation for a myriad of reasons, and I think a lot of these technologies are at least pointing in that direction. And with Vector, it seems to be about 70% of cases had anterior wall involvement.
Can I ask you about the right atrium? What percent of cases are you seeing triggers in the right atrium? Because I think it's a forgotten chamber when we start dealing with atrial fibrillation today.
In mine, I'll go just answer for myself. We've probably seen in about a third of cases. We've seen triggers in the right atrium. I think there are a few cases that they said, I think 20 cases, they had about 40% in the right atrium. I don't know. What about everybody else?
Yeah, we're sitting at like 40 or 50% with at least one spot identified in the right atrium. And then, as was mentioned, like, then you have to do some decision making. Which one of the sites are you going to target? What makes the most sense? Is it a first time procedure? Is it a redo, et cetera?
Yeah, and I think also I agree. We were about 35%, and now with the large PFA catheters, you do have to be a little cautious over there, because you want to try to avoid sinus node dysfunction and other things. But I think that the right atrium, I agree with you guys all. That's an important structure that we've sort of forgot about a long time ago.
Well, thank you, Saumil and Anish and Gery, for such a great session. The next session will start in a minute. See you there.